Before we dive in, a quick request. Please subscribe, like this episode, and tell us your next community medicine topic in the comments. Your suggestions steer our series. Welcome back, everyone. Today we unpack the modern, exam-ready approach to sexually transmitted infections, especially the syndromic management model you will use at the primary care level. With us is community medicine specialist Dr. Sharon.
Happy to be here.
To begin, let's set the frame. Dr. Sharon, how should undergraduates think about STIs, and why is the older term VD outdated?
Sexually transmitted infections are communicable diseases, primarily transmitted through sexual contact, vaginal, anal or oral, and in some settings through blood exposure or from parent to child. The term venereal diseases is now largely historical. Over the 1970s, agencies shifted to sexually transmitted diseases, and more recently, sexually transmitted infections, partly to reduce stigma and reflect that infection may occur without overt disease.
And the public health burden?
Big. Beyond immediate symptoms, STIs such as gonorrhea and chlamydia trachomatis can lead to pelvic inflammatory disease and infertility in women. Ulcerative STIs such as genital herpes and syphilis increase the risk of acquiring HIV, underscoring the linkage between these epidemics.
Pause and recall. Which STI complications are exam favorites? Answer: pelvic inflammatory disease, infertility, ectopic pregnancy, adverse pregnancy outcomes, and elevated HIV risk. Great. Now, the heart of today's topic, the rationale for syndromic management. Why not rely on laboratory diagnosis for everyone?
Etiological diagnosis, which is pinpointing the exact pathogen, it needs reliable labs, transport and skill staff. At the primary healthcare level, these are often unavailable or slow, causing loss to follow-up. Studies show that purely clinical diagnosis without an algorithm is often unreliable. Syndromic management emerged to close this gap, treat based on clusters of symptoms and signs that define a syndrome, and cover the major likely pathogens at the first visit. This approach, promoted by the World Health Organization since the 1990s, enables immediate, accessible treatment, better adherence, and fewer complications.
So, definition time, how would you define syndromic management in one Viva-ready line?
Syndromic management is a WHO recommended strategy that classifies patients by symptom-sign complexes, called syndromes, and provides standardized first-visit treatment for all key causative organisms of that syndrome using flowcharts.
Let's translate that to what we actually do in India. Walk us through the implementation and the major syndromes.
In India, syndromic care is delivered through Suraksha clinics, NACO-branded STI/RTI clinics, and integrated into routine services. You take a focused history, do a respectful examination, classify the syndrome using the clinic's flowchart, and dispense the color-coded drug kit. 6 high-yield syndromes to memorize: genital ulcer, non-herpetic and herpetic, urethral discharge in males, vaginal discharge or cervical discharge, inguinal bubo, lower abdominal pain in females, and scrotal swelling. Each has a standardized regimen.
Those color-coded kits always trip students up. Could you name a few correctly for the record?
Yes, memorize straight from the official poster. Kit 1, grey kit, urethral discharge, cervical discharge, and painful scrotal swelling. Covers gonorrhea and chlamydia etiologies. Kit 2, green kit, vaginal discharge, covers bacterial vaginosis and trichomonas with antifungal as needed. Kit 3, white kit, genital ulcer, non-herpetic, benzathine penicillin plus azithromycin. Kit 4, blue kit, non-penicillin alternative for non-herpetic ulcer for penicillin allergy. Kit 5, red kit, genital ulcer, herpetic, acyclovir based. Kit 6, yellow kit, lower abdominal pain, pelvic inflammatory disease regimen, treat the male partner with Kit 1. Kit 7, black kit, inguinal bubo, azithromycin plus doxycycline for 21 days. These standardize in Suraksha clinics across India.
Case Vignette 1. A 23-year-old man presents with burning micturition and a mucopurulent urethral discharge. No labs are available today. What is your syndromic plan?
Classify as urethral discharge syndrome. Provide Kit 1, grey kit, at first visit. Counsel abstinence or consistent condom use until cure. Offer partner notification and treatment, and schedule follow-up. Always offer HIV and syphilis testing via referral, if not already done, and provide condoms. Pause and recall. Which partners do you treat? Answer: recent partners, typically within the last 60 to 90 days as per clinic protocol.
Where do we refer and how are services organized?
India's STI/RTI services are provided free at designated clinics branded as Suraksha Clinic, usually at district hospitals and medical colleges, and supported by training, counseling, and color-coded kits. These clinics link with integrated counseling and testing centers, spelled ICTC, for HIV testing, and with reference labs for quality assurance.
Limitations are an essential Viva counterpoint. Where does syndromic management struggle?
3 areas. First, asymptomatic infections. Syndromic care cannot detect asymptomatic chlamydia in women or pharyngeal or rectal infections, so screening strategies are still needed in specific settings. Second, overtreatment. Because we cover multiple pathogens empirically, some clients with single pathogen disease receive broader therapy than necessary, common in vaginal discharge. Third, resistance risk and follow-up. If clients do not complete the full course or if drug resistance evolves, for example, gonococcal resistance, effectiveness drops. Hence, the push for algorithm updates and antimicrobial stewardship. Prevention and counseling are not optional add-ons. They're in the algorithm. What should interns always include? Comprehensive case management includes client-centered counseling, condom promotion and provision, syndromic treatment, plus partner management, and referral for HIV testing. Counseling should be tailored to the person's practices and values, which improves behavior change. That brings us to the sexual history. Many students freeze here. Any structured tool? Use the 5 Ps: partners, practices, protection from STIs, past STIs, and pregnancy intention. Open with confidentiality and non-judgmental language. For example, how many partners do you have currently? What kind of sexual contact do you have? Vaginal, anal, oral. How often do you use condoms? This ensures risk assessment and tailored counseling. Quick micro-viva. What is epidemiological treatment? Also called contact treatment. You provide a full therapeutic dose to people recently exposed to an index case while you arrange testing or await results. It interrupts transmission and is integral to partner management in syndromic care. Case Vignette 2. A 27-year-old woman has lower abdominal pain, fever, and vaginal discharge with cervical motion tenderness. What does syndromic management advise? Classify as lower abdominal pain syndrome. Think pelvic inflammatory disease. Give kit 6, yellow kit, at first visit. Advise abstinence or consistent condom use until cure and arrange follow-up at day 3, day 7, and day 14 and treat the male partner with kit 1. Counsel on warning features and ensure HIV and syphilis testing referrals. Let's connect dots with HIV. From an exam standpoint, how does STI control advance HIV prevention? Treating STIs reduces genital inflammation and ulceration, which in turn lowers HIV acquisition and transmission risk. Hence, STI control is a pillar of HIV prevention, and national strategies place Suraksha clinics and ICTC linkages side by side. Pause and reflect. Which STIs especially heighten HIV risk? Answer: genital herpes and syphilis, among others. Students often ask, is syndromic still relevant now that rapid tests exist? Your analysis? Yes, especially in resource-limited or first contact settings. The newest WHO guidance still supports syndromic management where access to etiological testing is constrained, while encouraging enhanced approaches, adding point of test as they become feasible to improve specificity and curb resistance. In short, syndromic first, plus testing when available. Time for a crisp conclusion. What should undergraduates write if the long question reads, Syndromic Management of STIs, Principles, Kits and Counseling? Structure it as definition and rationale, immediate standardized treatment by syndrome, closes gaps of lab delays, flowcharts and sites, implemented via Suraksha clinics, use clinic algorithms, major syndromes and kits, memorize kits 1 to 7 with colors and indications, highlight kit 1, gray, kit 2, green, kit 5, red, kit 6, yellow. Comprehensive care, counseling, condoms, partner management, referral to ICTC, and scheduled follow-up. Limitations and safeguards. not for asymptomatic infections, risk of overtreatment, and the importance of completing regimens and updating algorithms to address resistance.
Final action points for students?
1. Practice the 5 Ps with confidentiality and empathy. 2. Know your district Suraksha clinic for fast referrals and color-coded kits. 3. Never skip partner management and condom provision. 4. Document, follow up, and escalate when red flags persist. These small steps reduce infertility, adverse pregnancy outcomes, and HIV risk at the population level.
That wraps it up. If this helped your revision, subscribe, like, and drop your next topic. Maybe adolescent health or viral hepatitis at the community level. See you soon.